put that in our chat box or question and answer, and we'll focus on those questions and cases. So generally, over the years, when someone has asked about a case that involved difficulty with mapping, it'll come down to one of these 5 things most of the time. It's trying to understand what to use for mapping. What exactly is the signal of interest? It's sometimes hiding amidst a bunch of other signals, including noise, and to tease out what that signal is. I'll try to focus on this today. Toughest cases are where we map the earliest site, but that's not the place we need to ablate, not the earliest site. Mapping circuits, much more difficult than mapping other forms of arrhythmia. We've addressed this in some of our previous sessions and will do so in our case discussions. Then when the critical area for the solution for the case is missing from our map, we'll see if any questions come up on this. If they do, we'll share some cases with you. If not, we'll discuss at some future sessions. And then when it's more than one arrhythmia, when it's actually 2 things going on, 3 things going on at the same time, those are among the toughest maps to actually go through. As an introduction, I'll just show you a case, which is a 7th time ablation for an accessory pathway. And maybe I'll ask for volunteers from the audience to help talk me through some of these slides. Do we have any volunteers, Shar, already? Otherwise, I know Dr. Lee had already volunteered. If we could just pull him up as a panelist, we can talk. If other volunteers come up, we'll be happy to use as well.
Yes, hi, this is Justin Lee here, one of the electrophysiology fellows.
Right, so Dr. Lee, let me ask you this question. This is a 7-time failure in ablation. And we have here the resting ECG and then intracardiac signals.
Yes.
So if I were to ask you in this case, what is the likelihood that we'll have to ablate this pathway somewhere near the His bundle recording catheter? What would you say?
So just focusing on to the His bundle recording catheter, we see a multi-component signal.
Outstanding. So the first thing that Dr. Lee is pointing to here is, yes, we see a V that's timing with the QRS. That V is very late compared to the onset of the delta wave. But he's noticed this delta wave suggests something in the V is around this time and is wondering, could it be part of this multi-component signal? I think that's the key first clue that we need to find out what is our signal of interest. In other words, if we pace and produce maximal pre-excitation, if we took the ventricular electrogram as we usually do as the signal of interest, we would completely ignore this location. But if the signal of interest is hiding somewhere here, the true early V, the pathway signal, then this is absolutely a site that we would be interested in. How to figure that out? It's sometimes the best way to figure it out is the company the signal keeps. So here it would take some kind of dynamic maneuver. So we pace and we get the pre-excitation. We pace and lose the pre-excitation, lose the V, have V without pre-excitation, dissociate, and this signal disappears. This signal keeps company with pre-excitation. It does not keep company with the atrial electrogram. That means it's not A, and it's critical to the pre-excitation. And this was the exact cause of difficulty why so many failures were present for this case. So once that's appreciated, then it's a question of simultaneously recording a good His signal when we have less pre-excitation, recording these signals that we know are related to pre-excitation, and then appreciating what we should see once successful ablation is done. The A will stay the same, this V will move with the QRS, but this should be gone. And that's what you get at the end of success with that case. So the signal of interest comes up in multiple causes of difficulty with mapping. And sometimes when it's not obvious, the key is to do something with the signal and see if that's really relevant to the case. Another example here, patient getting ablated for PVCs. But just during sinus rhythm, wherever this catheter is, we notice the ventricular signal has more than one component. One far field, another one sharp and relatively late. Now, sometimes we don't actually have to do a maneuver. When the patient's PVC or VT shows up, we notice the signals have flip-flopped. The near field signal is coming earlier than the far field signal, telling us that wherever that catheter making contact with tissue, the near field signal, that's critical to this arrhythmia. This can greatly make a difficult mapping case quite simple, because all we need to do is map the structures that give you this late near field signal in sinus rhythm, but flop or turn around and become early when we're actually having the arrhythmia. So signal of interest, very important, and something that throughout this series, you'll see as a theme that comes up when addressing a difficult type of question or scenario. Brief comments about not the earliest site. This is important because electrophysiology evolved ablating arrhythmias that we find the early site and we ablate. As a result, whoever was your teacher, whoever was your mentor, grew up in that era. As a result, mapping systems got really good at that approach. So what happens is whichever mapping system, whichever approach you have, when you now have to ablate at some other target that's not the early site, it becomes a difficult mapping case. Let me share a couple of examples with you. So if no other volunteers, maybe I'll ask Dr. Lee again. Dr. Lee, this is a patient with palpitation, and you have to pick a site where you want to ablate this person's arrhythmia. Any thoughts?
So here we see tachycardia with left bundle branch kind of morphology with a left superior axis.
Excellent. So with the wide complex tachycardia, if this was a VT, we would say right ventricle inflow somewhere near the exit of the right bundle branch. But suppose this was a young patient, structurally normal heart. Any other arrhythmia come to mind where you could have the earliest activation in the V a little further away from the annulus that's actually an SVT? Or a type of pathway maybe that actually exits closer to the conduction system exit rather than the annulus?
One possibility is a Maheim type.
Outstanding. So an atriovesicular tract. So one of the things with mapping an atriovesicular tract that makes it so difficult for so many people historically and even today, a very common cause of failure, is trying to get their head around the concept that sometimes we don't ablate the earliest site. So here, a catheter is pointing kind of on the annulus posterolaterally, and that records a signal. Now, the ventricular electrograms are actually late at that site. So mapping the earliest V, like we would for many other pathways, simply won't work because the actual V at the site of successful ablation is going to be late. This is because of this conduction tissue that's ensheathed and taking this signal, this pathway signal, a long distance down towards the ventricle, close to the right bundle exit where you had anticipated. So you don't ablate the early V. You'll have to identify where the signal is. Here, isthmus type recording catheter on the free wall, finding that signal and ablating. The atriovesicular tract that you mentioned as the diagnosis is the correct one in this case. It's unique in pathways because we don't ablate at the early V. We don't ablate at the early A because the early A is never related to the pathway. No retrograde conduction through these type of pathways. So the target is something else. Another very important scenario is when we have early activation at this site during a whole plethora of SVT types. So Dr. Lee, do you want to tell us where is this location of this catheter that I'm pointing to here? RAO view, CS is in place, his bundle recording catheter, and then this one.
So with the His bundle recording catheter being at the septum, that can kind of define the septum on the LAO view. And on the CS catheter, we can define the atrium versus the ventricle. So the ablation catheter looks like it is behind the CS catheter, so more atrial and more septal. So and it's more leftward on the septal. So
leftward,
pointing,
slipping behind the tendon of Todaro. What is that?
So when we go more leftward to this, the tendon of Todaro, that would be the fast pathway region.
Fast pathway location, excellent. So of all the SVTs that we deal with, most of the time we have a solution. We can map the early site. So pathway, atrial tachycardia, focal atrial tachycardia, and even an AV node reentry, when the retrograde limb is anything other than this location, we can map that early site and ablate. But when this fast pathway site is early, it's one of those scenarios where we cannot ablate them. So sometimes we've found out it's typical AVNRT and we know where to ablate. Other times, other variants, other diagnoses, we don't have that and it becomes a difficult map to figure out where else in the circuit you can ablate. But this overall concept of early site is not where we want to ablate is important in a variety of scenarios, common conditions. For example, reentrant VT. The early site could mean very little in terms of successful location. When we have an entrance to a chamber that's giving the appearance it's early. Any conduction system arrhythmia, vesicular tachycardia, Purkinje PVCs, the early location is very nuanced in terms of its relationship to what the actual arrhythmia or site of ablation should be. So maybe I'll stop there. I know we have several questions that we should discuss, but these are two that I would say is thematic. Find the right signal and understand when the early site is not your target. So always two good checks when we feel we can't understand a map or we're failing to ablate an arrhythmia. So Char, I know you put up the questions. Siva, Abhishek, anything that you feel we should tackle first? So we have a question of how to use the unipolar recordings for mapping. How do you use the unipolar recordings for mapping? Maybe I'll just ask Abhishek, do you want to take a shot at that one?
Yes. So unipolar mapping is helpful when we are on multiple fronts. Number one, if we are mapping or doing an activation map for a focal arrhythmia, say a PVC, and we are mapping the outflow tract, and then if we find a site, then we can certainly look at the unipolar electrogram to look at the QS and then try to see if we are getting an ideal QS that might be suggesting from where the PVC focus might be exiting from. Some other times it can be helpful is that we may think we have an early signal, say in one chamber or around one structure. But if you look at the unipolar electrogram, there is a chance you might see something far field, which is even more earlier. And that may suggest that you might be in the vicinity, or you may want to map the adjacent structure. The third time I look at unipolar, sometimes it can also tell us how the contact is at that particular location. If we start to see the STs kind of going up on the unipolar signal, that can be helpful. And these are the kind of times when I think of unipolar mapping specifically. So there are obviously reports that, if you do a voltage map, and then you can also look at a bipolar voltage map, you can also look at the unipolar voltage to see what is the voltage at a slightly distant area, say endocardial map, and looking at epicardial voltage. Those are some of the other uses of unipolar signals and unipolar mapping. But even when we find the earliest site, there are certain interesting signal patterns on unipolar signals which I look at that could mean some notching in the downslope of that signal to see whether we can identify whether that's the true exit of those PVCs. And maybe as you discuss more, I'll pull up an example.
Great. So maybe we can go through each of those in detail. So that's a very nice detailed discussion about multiple uses for unipolar recordings. Just to get everybody on the same page, there is really no true unipolar recording. It's always a bipole. It's just, the indifferent electrode is just something very far away, or it's guaranteed that you don't have any signal from there. Then that unipolar recording becomes like a probe that you can move around to try to understand the arrhythmia. So the basic principle is unipolar recordings are going to give you a very good idea of how far away are you from the source. So how far away from the source? So for example, in this classic paper from Dr. Stevenson, the further away we are from the source with our positive electrode, just like we do with ECG interpretation, the bigger the R wave. The smaller the R wave, the closer we are. And when we actually have a QS complex, then we say we are at the site of origin of that source or that focus of arrhythmia. So Abhishek pointed out some of the difficulties and some of the alternate uses. So this is the easiest, simplest case scenario where we have a focal source arrhythmia. We get a near field bipolar signal telling us contact is good. And then we have a QS with the unipolar electrograms. That's our best case scenario. But let me share with you some situations where we either have an alternate use or it is difficult to actually use this concept. So for example, we have one common scenario where unipolar is misleading, where we have a focal source arrhythmia. The bipolar signal is late, but the unipolar signal is a QS. So this caveat is very important unipolar signal is very sensitive to contact. So if you keep an endocavitary catheter in the blood pool, almost any site will give you all wave fronts away. For endocardial to epicardial activation, it's going to show up as a QS. So if you use unipolar, first thing you want to say is, how is my contact? Is the contact reliable? Then you start thinking about using it. Second big caveat is, what are you using to create your unipolar recording? The most common is using the Wilson central terminal. So just like an arithmetic game with the ECG leads to create a zero potential, and that's used as a reference to generate our unipolar signal. Put another way, what this is saying is your unipolar recording is as good as your ECG. If your ECG has random noise on it, you're always going to get baseline waiver on your unipolar recording. So if you're looking at small signals, good timing, it becomes very difficult to use the unipolar recording. So some operators will get a dedicated catheter for unipolar recording, typically in the IVC, and no signals there, should be like pretty clean signal, and that can be used to generate the unipolar. The third is something that Abhishek pointed out, and that is, if you are recording from the internal surface, the endocardium, any source that's on the epicardium will always have some wavefront towards your roaming catheter. So it's impossible to get a QS complex. There's always going to be something that's moving towards this catheter. So how do we use the unipolar to record at that time? So one way to do that is to see on the unipolar, what is the timing for that starting of the R wave? So we see this, which coincides with our bipole, but we use this to try and figure out about where will we be opposite to that early site, and could potentially ablate if we are not actually getting epicardial access. And the last one, Abhishek mentioned it, but I think is a very important one that we get lots of questions on typically, and that is what if the bipolar signal is great? So opposite as scenario one, but the unipolar signal is late. And a caveat where sometimes we'll see a small unipolar followed by a large unipolar signal. So maybe I'll get thoughts from Dr. Lee again. Why would this be, Dr. Lee? Why would it be that the unipolar signal is actually later than the bipolar signal? Bipolar signal, we're right there. It should give us this QS complex.
So possibilities of why there can be a very late unipolar signal compared to bipolar. I'm thinking maybe one possibility that the bipolar is actually a far field signal and the local signal is defined by the unipolar.
Could be, it could be, but the bipolar signal, when it's sharp, usually means that's the tissue that you're touching. You're right, if we saw something very far away, but that should mirror the unipolar, because if a bipole can pick up something far away, for sure, a unipolar big antenna should. But consider this scenario. What if the real arrhythmia is a supravalvular focus? And the supravalvular myocardium is limited, it's very little. And that focus has to travel to get to the bulk of the myocardium, which is huge. So our catheter here is overwhelmed by this large signal with the big antenna of the unipolar, that is what's producing the QS. Now, if there is enough muscle there, we may see this so-called W pattern, where we have a small unipolar that tells you're at the focus in the little part of myocardium prior to getting to the big part of the myocardium. So unipolar having this pattern slightly negative, then very negative. But the bipolar signal, however small it is going to be sharp and giving you the control there. So consider your cases where you've had pulmonary vein ectopy or a supravalvular source of PVCs. Sometimes even focal arrhythmia in the middle of diseased tissue or scar. Those are times when we would get this mismatch. So
Dr. Hassan, can I show you an example to show this?
Yes, please do.
As you
go ahead, share. You could share your screen.
Yes. Give me 1 second. Give me 1 second. I'll pull it up. You can keep going.
Okay. So let's look at some of the other questions here, and anything that Siva or Chris have seen something we should answer now. So one that I see here is a question on clipping and filtering. So it's a very important. Do you want to go over yours or?
Yes, I'll just show you this.
Okay.
So we talked about this was a PVC we were doing, outflow tract. And with mapping, this was the best signal what we had in the right sinus of Valsalva. And with the unipolar signals, as you pointed out, you could clearly see these multiple bumps or conduction break of that wavefront, which is coming through because of being deep in the cul-de-sac, that the wavefront can actually even split. That can give you this kind of two humps in the downslope of the QS complex.
Excellent. Thanks a lot. So, Siva, you had answered that question that one of the doctors had about filtering and clipping.
Yes, in general, we try not to have clipping on, at least on the mapping or the roving catheter. So once you turn the clipping on, you lose some of the frequency content. And not only that, when you turn clipping on and when you start filtering, some of the things get amplified, and you tend to create new artifacts. So at least on the mapping or roving catheter, it's best probably not to clip on the bipolar signals.
Yeah, I think that's a really important question and point. And as time goes on, we probably these will get to be less of a problem. But this is a example, something as simple as an electrical noise filter, where the frequency, predictable frequency of what's causing this kind of background artifact, electrical noise, AC noise. So if we put that, it does clean up your signals. But what can happen is just look at the quality of these pulmonary vein signals. Nothing has been done here, and it looks like you've done a magical ablation. It's because there are shared frequencies that noise and cardiac mapping have. So you can't have one without the other. If you filter based on frequency, you may get rid of the undesired frequency, but we're also going to get rid of some of the things that may be key to mapping. Another issue, an allied issue we don't talk about very much, is also the sampling rate, or what's the frame rate for the recording. And many times when fellows who are trained and then they're getting a job and people see how great they are, they'll get an offer from their hospital saying, You can build your own lab. What system do you want? What do you want? And most of the time, you look at a lot of characteristics of how the map helps. But one of the fundamental things about the system is the frame rate. And this is an illustration. This is the same signal. But you can see when you have poor sampling rate, a lot of the things like what Dr. Deshmukh pointed out, the notches, the glitches, the changes, the early signal, all could disappear because we just don't have the sufficient sampling rate to really bring it up. So that's a couple of things related in addition to what Dr. Mulpuru pointed out. So I see another question here. I think basically what it is asking about when we are doing a map and we don't actually figure out an early site. And I think what they mean is for a focal arrhythmia, when there really is a source, but we're not able to find that site. And this leads us into a difficult type of mapping, which we call comparative mapping, trying to anticipate where the early site is when you haven't actually mapped it by looking at stuff that may be around that site. So maybe we'll address that, but let me just ask as a lead-in first, maybe Dr. DeSimone, have you had this situation that the doctor is asking about where it's a focal source, but you're just not finding that earliest site? And then what's your approach to think that through? And then maybe I'll follow with a few examples.
I never really have. I usually just, if that means I haven't found the earliest site, it just means I need to keep mapping more. So making sure I'm doing all the chambers and going to opposite sides of each septum that I'm at, and making sure if I'm doing automated mapping that I'm self-annotating each of the signals. Usually those will help get rid of that. The other thing is sometimes you just have to stop and say, maybe it's not a focal AT, maybe this is a reentrant or other mechanisms, and then have to do some maneuvers to really prove it. So I think the key is not getting stuck and saying, look, it's focal, it's focal, it's focal. Where's my early? Then start trying to do other maneuvers, entrainment, things like that, and see if this is really automatic or not. If there's things where you're trying to allude to where you need to do comparative mapping or something involving the conduction system and comparative mapping, then you need to do something as a reference. So for example, if you need to do something in sinus versus PVC that's coming from a vesicular system, your HV there is not going to be the same. So you could map when you're in sinus and then map during your PVC, and you can kind of compare your HVs. So you're are you downstream? Are you at the right spot? If you keep going further, are you proximal to it? I think those would cover those things. So is it the right type of mapping, right type of AT? And then if you need to do something as a fiducial point during sinus.
So you brought up two important concepts. So, you use the word comparative mapping. And then the second is, the statement you made, very telling, that you don't come out of a case without understanding where that early site is, because when you don't, you have a method to troubleshoot. So let's explore both of them. And I believe for that second concept of comparative mapping, Dr. Mulpuru has a case to share with us that we could today as well. So, so if we look at this idea of the first point that Dr. DeSimone brought up, and that is, where do you anticipate that you need to go and find that early site? I mean, I personally cannot overemphasize this. I tell this to myself every time. If you're doing a case and if you're not finding a great site, it's so tempting to just take your best shot. But you've got to tell yourself there's got to be the real location somewhere and what can I do to try to maximize my chance of getting that? And it's that simple moment that you step back and say, I need to look further, can really be the difference between success and failure. Now, sometimes we can't because the patient is sick and we just have to quit. But the answer is rarely, let me just take my best shot, when you know it's just nowhere near where we are likely to find an early signal. So let me use this example. This is an example of a patient who had had ablation for AFib, but really retrospectively, when we looked at this case, all along, it really was probably an atrial tachycardia, okay, or some focal source tachycardia. This was the P-wave morphology, and this was an extensive set of electrodes for mapping. We have coronary sinus, we have a His recording catheter, and then we've also got a right atrial catheter. So, and if we then added also a catheter that you place in the left atrium, kind of opposite the septum here, we find something kind of curious. Recording catheters at disparate sites, sites quite far from each other, the His recording catheter, the coronary sinus, and an ablation catheter across the septum. None of them are very early, but they're all equally early. So maybe I'll ask Dr. Lee here, what does this mean to you? And where do you feel we should continue to map?
If 3 spots are kind of like, for example, equidistant or not equally early, then it's somewhere in between all of them.
So excellent. So this is, I think, a type, this is a form of comparative mapping. That is, if 2 sites are equally early and it's a focal source tachycardia, we know neither can be the focus because you can't zip from one location to the other. But it's still giving you some information that says, think what could be in between. And maybe when you map there, you'll find the true source. Any suggestions, Dr. Lee, on where the map should be done? This was a case from our colleague, Dr. Friedman. So if he was relying on you for advice, where would you tell Dr. Friedman to map next?
So here we see we have a septal A by the His catheter. We have a CS.
Yes.
And we have the ablation catheter septal and pointing backwards to the septum. If all 3 are late, I think one spot would be the non-coronary cusp.
Excellent, excellent. So this is the picture that Dr. Lee is carrying around in his mind. He's thinking, like in this particular case, it happened to be actually slightly away from the non-coronary sinus, but that would be the way that you would think about this. So you'd say, look, I've mapped here, I've mapped here, I've mapped here. What's living in between that I haven't mapped? And then you find, and then it's some fine mapping in that region. The non-coronary sinus, the right sinus of Valsalva, all are not one points, they are some distance. So you have to do further mapping in that area. But even that, you might have been helped, which was a little earlier. Was it the His A? Was it the CSA? Was it the left-sided A? Even if it might be a few milliseconds, but may give you a clue which way to go to get to that side. Really nice. Sometimes what it is a little bit less obvious if we have a wide area. So all of this is kind of giving you a very similar time. If it's so wide, it probably is a structure that's in the middle, but a different plane, epicardial, endocavitary structure. This case, you could find that site that explains the whole map for a focal source tachycardia and was like on a papillary muscle. Siva, do you want to take that first aspect of what Chris brought up for explaining this doctor's question? That is, another idea in comparative mapping, that is, where can we find where that source might be, not comparing different points in the map, but comparing the same point in two different rhythms. Maybe
Definitely, Sam.
And sinus.
I'll bring up my screen. Okay, so this is a case of a young 25-year-old patient with a lot of palpitations. So he has frequent palpitations, and this is his 12-lead ECG. So on this particular ECG, we can see there is almost a trigeminal rhythm. We see this beat kind of narrow, but does not look like a conducted supraventricular complex. Inferior leads, it's taller than in sinus rhythm. And more importantly, when we look at the T wave, there's really no P wave beforehand. So he has this particular ECG, when he presents to the clinic. So on a Holter monitor, because of this narrow beats, the monitor actually calls it as supraventricular beats, about 30% burden here. And when he presents to the lab under sedation, initially he was in junctional rhythm, but we still see these ectopic beats that are happening, kind of narrow, but with a different axis. So the idea of comparative mapping is on the left side, if you have a supraventricular conducted beat, and if you have a His bundle catheter, the HV interval is a time taken to activate the His bundle and the time it takes to travel down the His-Purkinje system and to activate the QRS complex. Suppose if you have a focus that is in the conduction system that's actually causing the ectopy, like in this right-hand screen, the HV interval recorded during that ectopy is a pseudo interval because this focus is going to conduct antigradely and inscribe a QRS, and at the same time it is going backwards to the His bundle area. So this HV interval is a pseudo interval, and we will illustrate that in the next few tracings. So we take him to the lab. Here we have a His bundle catheter in yellow color, has a CS catheter. The first 3 beats are sinus beats, and then you have this beat, which is kind of narrow, but more positive in the inferior leads. And we see a His bundle signal here. So when you look at this, you may think that because there is a preceding His, you may think that this is a supraventricular conducted rhythm, but the key point is to compare your HV interval in sinus rhythm compared to this ectopic beat. If this were a true supraventricular rhythm, this HV interval should be very similar to the sinus rhythm HV interval. Sam, you want to add anything here?
I think that's a fantastic explanation. Maybe I'll just draw a figure here to kind of illustrate that, and then any other points that anyone likes to make, please do. So really very simple but effective point that Dr. Mulpuru has made. Comparing the same point, so it's one point that we're mapping, and we have a signal or a set of signals, but we're comparing that point in 2 rhythms. This comes up in a variety of arrhythmias, from structural heart VT to fascicular VT to atrial tachycardia to junctional tachycardia, many different arrhythmias. But the case that Dr. Mulpuru pointed out is a very good example of this concept. Same point, 2 rhythms. So during a conducted beat, we have a His, and then we have a V And we just go from the his to the earliest V anywhere. And as Siva said, if we have a SVT, if we have a nodal tachycardia, if we have an atrial tachycardia, the his to V shouldn't care about the source of the arrhythmia, should be the same. But if that his to V is shorter, doesn't matter that the his is before the V, it is not a supraventricular arrhythmia. It's something that's originating below the conduction system at the recording site. So if recording site is here, but arrhythmia is here, you may get to the V relatively earlier than you do to that recording his. Now, someone might say, do we really need to know this? Because we can do a multi-recording on the his and show is it antegrade or retrograde. But this is actually very difficult to do because getting the recording catheter lined up with the his is tough. One or two electrodes may be off axis, become far field and give you a different sense of timing. Now, an extension to what this is if instead of recording now by the his, if we record on the left posterior fascicle, let's say in the proximal part of the left posterior fascicle, and in sinus rhythm, we get an electrogram that has this timing with the V, but during arrhythmia, we have one that has this timing with the V, where it's still shorter during the arrhythmia compared to conduction. That tells you you need to go even more downstream. And eventually, at some spot, you're going to have a match of conduction interval with the arrhythmia interval at that site. Now, does that tell you where we need to ablate? No, but it tells you don't waste your time anywhere higher than that. Why doesn't that give us the site to ablate? One, a very, very difficult scenario where we actually have a re-entrant arrhythmia, and we have to use our other skills for circuit mapping and trainment. But even with the focal source arrhythmia, anywhere below the focus will also produce the same match. So you'll have to understand the axis of the conduction system and find the highest possible site where you get the match, because anything lower than that will still match the signal. So the highest site that gives you that, you're probably at or very close to the focus. Now, there are many other situations where this is of value as well. For example, if we look at this, this is a case where this exact concept helped me out. So this was a patient with a severe cardiomyopathy, actually had a storage disorder, severe cardiomyopathy, ICD shocks, and showed what we are seeing on the signal, that is more V's than A's, more V's than A's. Cardiomyopathy, more V than A, got to be VT. So we induced tachycardia and put in catheters. And what we notice, yes, more V than A, absolutely. But all the V's have a his bundle signal earlier. So now we're thinking, well, VT, but with the his signal being earlier, bundle branch reentry. However, we used exactly the idea that Dr. Mulpuru brought out. Compare with the sinus beats. And when we compare with the sinus beats, it's exactly the same. It's exactly the same. That means this is a conduction interval that's being measured, not a pseudo interval. So if that's the case, no, it isn't VT, no, it isn't bundle branch reentry, it's an SVT. And if it is an SVT, and if we had only this beats all the time. With the VA very short, HA short, we'd say it's AVNRT. And then the thought process became more on like what type of AVNRT can we get more V than A? We then defined it to be a type of AVNRT where we have this so-called upper common pathway block, and it was slow pathway ablation that was curative in that patient. Now, just to emphasize why bundle branch reentry was not the diagnosis when we considered is because in bundle branch reentry, right bundle, left bundle, retrograde left bundle, antegrade right bundle completing the circuit. The hiss itself is not part of this circuit. The circuit involves the bundle branches. So right bundle, left bundle. Since the hiss is not part of the circuit, the HV in conduction with a sinus beat reaches the hiss and then reaches the V. But in tachycardia, we have a turnaround below the hiss that gets you to the hiss while en route to the V. So the HV is shorter during tachycardia in bundle branch reentry compared to a sinus beat. The right bundle, we're at the right level that's housing the circuit, so the intervals are the same. The hiss is higher, same principle. But this case, it was exactly the same. So telling you, look ahead, look higher. And which arrhythmia will you need to look higher, and yet you can have more V than A. So you think AV node reentry, you think of a junctional, high junctional tachycardia, maybe nodovesicular tachycardia. So then we look at which beats can we understand, focused on that and did the ablation. So two kind of takes on what this term comparative mapping means. One that Dr. Lee and Dr. DeSimone mentioned about find multiple sites, see what's early, triangulate in your mind and see what that early site is. Another, what Siva brought up, is comparing the same location with two different arrhythmias. Future sessions will kind of emphasize that concept when we look at difficult substrate maps. I think that was another question that came up as well. One of the other questions there was about also about unipolar recordings. When and how can it be isoelectric? We can address that in the recorded session. And then we have some, I think, related to substrate. So we did a little bit of substrate at one of our last sessions. We have a special session coming up, and Shah, remind me of the date, where we'll have one of our cardiac pathologists sharing a case of a patient who died and had an autopsy, and we will backtrack what substrate had as a role in that patient's death, and that will give us an opportunity to understand a little bit more about substrate, and we'll answer that question. Few of the other questions here we'll address in the recorded session. Shah, do you have the date for when we will be doing the substrate with Dr. Boyce, our cardiac pathologist? So whoever has had that question, be sure to join and we'll discuss there.
It's our next session on the 28th of April.
So it's actually in 2 weeks. So we'll have that and we'll explore those thoughts a little bit further. Well, thanks everybody for joining, and we'll work on answering the rest of your questions. I know we didn't get to much, but at least 2 or 3 others we'll discuss and have as answers that we'll post along with this recorded session on YouTube. Thanks again. Thanks, Justin. Thanks for joining us.
No, thank you.